Yes, ma'am, you can start now.
Can anyone confirm if my screen is visible? Yeah, is my screen visible? Alex,
Yes, ma'am, your slides is visible.
so, can we? Okay.
You go to the full screen mode. Yeah.
So, good evening, everyone. Firstly, welcome to today's KT Live session. Thank you so much for giving us your precious time. So, to begin with, I would like to first welcome all our esteemed panelists for today's session.
Kalpita, your audio is very poor. There's a lot of echo.
Just a minute, sir. Just a minute.
Or you can share. I will just. Research needs no introduction. Everybody knows, sir, but I'll just you put in the slide there.
Ma'am, sir, ma'am has just left.
Now,
No, it is again the voice. There is some issue with the net. So you can share the slides and
just a minute, sir. Is my screen visible now?
not yet, but it should be.
Yes, ma'am, your screen is visible. Just open the presentation.
Yeah. Is it visible?
Yes.
Okay. So sorry for the inconvenience. We'll begin by introducing the esteemed panelists for today. So first we have Dr. Subhash Kaur. Sir is a highly skilled neurologist at the Department of Neurology at KIMS Hospital in Hyderabad. Sir has more than 40 years of experience in the medical field with around 105 publications to his name and has contributed to almost 20 book chapters. Sir has delivered more than 300 lectures, including orations in the last 25 years. Sir has also been a part of various clinical trials, national and international, that were ICMR funded. Sir has also been an expert reviewer and member of the editorial board for different journals, more than 50 students in the DM neurology sector. Sir has a long list of awards and honors to his name. He has been awarded the State Teacher Award by the government of Telangana. He has also been the past president of the Indian Academy of Neurology, the Indian Stroke Association, and Andhra Pradesh Neurology Association. Sir has also been the Jacob Javits Stroke Fellowship at the University of Maryland, Baltimore, and has done a fellowship in American Heart Stroke Association. Sir has also been a fellow in the American Academy of Neurology and the Royal College of Physicians, Glasgow. We are happy to have you on board, sir.
Thank you.
The next we have is Dr. Praveen Kumar. Sir is a consultant neurologist at the KIMS Hospital in Hyderabad. Sir has completed his MBBS from the MPCG Medical College and has completed his in MD in Spania Medical College, Hyderabad. Sir has also done his DM in the neurology at the Nizam Institute of Medical Sciences, Hyderabad in 2013. Sir has also been a part of various presentations and conferences like the APNSX 2011, Econ Hyderabad 2013, API 2006 Guntur, and CUNY Bangalore 2012. Sir has also been a co-author of the chapter in tropical neurology and a member of IA and ISA in 2011. The next we have is the speaker, Dr. Shrikant. Dr. Kaur, I would request you to kindly introduce both the speakers. So I'll just run through the slides if that's okay with you. Hello.
Hello. Good evening, respected Dr. Suvash Kaul sir, Dr. Praveen sir, my co-speaker, Dr. Vijay Kumar sir, and all my seniors and dear friends. I am Dr. Srikant Koguru. I did my DM neurology from SWIMS Tirupati and presently practicing at Mahbub Nagar as consultant neurophysician at Sri Balaji Neuro Super Specialty Hospital.
Yeah. Welcome.
Yes, sir. So, is my screen visible?
Yes.
Yeah. So, today I shall be presenting a few interesting stroke thrombolysis cases that were recently managed at our hospital.
Excuse me, sir. Sorry, your screen is not shared.
Not yet. My screen visible, sir?
Yes.
Yeah. So today I shall be presenting few interesting stroke thrombolysis cases.
Make it a slideshow.
Yes, sir. That were managed at our hospital in the last month. Now, case we net one, the first case is a 56-year-old male patient, no previous comorbidities. He came with complaints of fever since 3 days, occasional headache, one episode of vomiting. Presently came with loss of speech since three hours, associated with difficulty in walking and altered sensorium. On admission, patient was drowsy. He was not obeying commands. BP was 160 over 90 mm mercury. Pulse was 84 per minute regular. GRBS on admission was 112 milligram per deciliter. GCS was 10. Neurological examination, he was aphasic. There was paucity of movements in right lower limb. He was moving both upper limbs against gravity. And NHS score on admission was 13. So provisional diagnosis was acute meningoencephalitis with stroke in window period. The other DD would be stroke mimic due to acute meningoencephalitis. So CT brain was done as patient was not cooperative for MRI. A CT brain showed no IC bleed and there was age-related cerebral atrophy. The dilemma was whether to thrombolyze this patient or not. Because the diagnosis was uncertain, it could be a stroke mimic due to encephalitis, meningoencephalitis. The other thing is increased risk of hemorrhage post thrombolysis if it is meningoencephalitis. So intravenous thrombolysis in the setting of acute meningoencephalitis is risky and it's a relative contraindication. And data is limited as blood-brain barrier is already compromised, there is inflammation and there is increased risk of hemorrhage. But considering the symptoms were less than 4.5 hour window and the deficits were debilitating, thrombolysis was considered. Patient was thrombolyzed with injection tenecteplase 15 mg. He was around 60 kg weight and lab parameters were normal. Patient was started on empirical antibiotics for meningoencephalitis, Monosef 2 gram BD, vancomycin 1 gram BD. Antivirus were started, injection acyclovir 600 mg IV TID, and dexamethasone was also started. CSF was planned the next day, and MRI was done the next day. And MRI showed acute infarct in left frontal operculum. As you can see, there is a diffusion restriction there. And angio was normal. The second day, CSF was done. CSF showed elevated protein, 74, sugars for normal 50, cell count was 88 with lymphocytic predominant cell count. AD was normal. The gram stain was negative, AFB was negative, CB naught was done sent, and it came negative later. And it was consistent with viral meningoencephalitis. So after treatment, patient showed improvement after 3 days. He was able to speak with mild dysarthria. He was able to walk with minimal support, and he was discharged on oral antiplatelets, statin, IV acyclovir for 17 days. Already 4 days it was given in hospital. Patient came for follow-up after 1 week. Few days back he came, and there were no deficits on follow-up. The NHS score after 1 week was 0. So case minute 2, she's a 60-year-old female patient, the known hypertensive. She had a recent history of cataract surgery. It was done 15 days back. She came with weakness of left upper limb and left lower limb for 2 hours. This was associated with slurring of speech, deviation of mouth to right side. On admission, she was conscious, coherent. BP was 150 over 80. Pulse was 96 per minute regular. Sugars on admission was 88 milligram per deciliter. Neurological examination showed she had dysarthria, left human facial palsy. Motor examination, upper limb right 5 by 5, left 2 by 5. Lower limb right 5 by 5, left 2 by 5. NIHS score on admission was 9. MRI was done. An MRI showed acute infarcts in right corner radiata, posterior limb of right internal capsule, and putamen. MRI angio showed non-visualization of right ICA, MCA, and ACA. A list of thrombosis of right ICA. So question arises whether to thrombolyze this patient or not, because there is a recent history of cataract surgery. Although it was more than 14 days, the potential risk of orbital or intraocular hemorrhage, which might lead to permanent visual loss. So patient was thrombolyzed with injection technique to place 14 mg. Weight was 48 kgs. She showed improvement after 2 days. At discharge, she was able to walk independently. NHS score was 5. So after searching literature, thrombolysis shortly after cataract surgery it was not an absolute contraindication. It's likely a relative contraindication in this case. Data in this cases is sparse, and there are no large reviews confirm safety. And there is a definite, there are a few case reports showing intraocular hemorrhage and orbital hemorrhage, and conjunctival hemorrhage is also reported, hyphemus. There may be transient weakness in transient visual loss in case of conjunctival hemorrhage and hyphemus, but few case reports were reported showing a sight-threatening bleeding. It was permanent. So this is one case report of orbital hemorrhage that resulted in permanent visual loss, which was reported in 1997. And this was of post-MI thrombolysis. Patient had hemorrhage and we had permanent visual loss. This is another case report of vitreoretinal hemorrhage after thrombolysis in acute stroke, who had permanent visual loss. So in such cases, we have to individualize the decisions. We have to favor thrombolysis in disabling stroke. We have to take an ophthalmology consultation. There should be stable post-op eye, and there should not be any inflammation. There should not be any active bleeding. We have to consider mechanical thrombectomy alone for large vessel occlusion. In this case, we have advised them to go to higher center for mechanical thrombectomy, but they were not willing due to logistic issues. And we have to monitor for ocular bleeding post cataract surgery. Thank you.
Yeah, thank you. Dr. Praveen, are you around?
Yes, sir. I'm here, sir.
Yeah, your comments, please.
Yeah, the first patient, definitely always a dilemma whether a patient with infection or whether patient any problems we should thrombolyze or not. But as over the time we have seen, even the patient with tuberculosis, there are many case reports in which thrombolysis has been done. Therefore, definitely the CSF picture looked like a possible viral meningitis. And cause of etiology of stroke, I couldn't, because the vessels look good enough. Therefore, whether it was a small vessel involvement, that was a thought. the good thing is that patient had a wonderful recovery. And definitely thrombolysis after cataract surgery, as Dr. Srinivas rightly pointed out, is always a decision which has to be individualized. But if the NIHS is, if the stroke is disabling, as we keep on seeing, the contraindications are getting less and less. And the point is that whenever you have a stroke, do thrombolyze. And I definitely agree, mechanical thrombectomy as it was offered, it is a challenge because of the financial issues. But when nothing is available, many times we see simple IV tenectoplase doing the trick. Therefore, the good message, as sir has pointed out, that all cases of thrombolysis we should individualize, and we should err in thrombolizing rather than just hiding behind some relative contraindication. I congratulate the doctor for doing thrombolysis in and helping the patient for a better recovery.
Thank you.
Thank you.
Thank you.
Yeah, I think as far as infection is concerned, the only absolute infection which is an absolute contraindication is infective endocarditis. Short of that, I think one can thrombolyze. There is no contraindication. Except infective endocarditis, we have to make sure that in any suspected infection, we have to make sure heart should not be involved, because that is disastrous. Other than that, we can thrombolyze any infection. And as far as the cataract is concerned, I think now cataract is a very avascular surgery, and you can even thrombolyze on the same day also. Cataract is that condition. In fact, you need not stop aspirin also in these patients, even though ophthalmologist asks us to stop, but it's not necessary. And I remember many years ago when the indications were still evolving, Dr. Murli was one of our students, and once he became a consultant, one day he called me that the cataract, and post-operatively he got a stroke. And we took a chance and we thrombolized because indications were not clear. But eventually, we have surveyed the literature and all, and you can. I think you did a good thing, and your patient also did well. So these are good cases. I think there are more and more indications are there, less and less contraindications, but still we should be very careful. We should make sure that we are not, for instance, checking. No, I'll tell you, in ophthalmology, even small vitreous hemorrhage, micro hemorrhages, they are also not a contraindication. You may call them a relative contraindication, but they are not absolute contraindication. So finally, you have to balance. I mean, you have to balance the risk and the benefit. And sometimes for getting a potential benefit, we have to take a little risk. So I think that's what you have done. So congratulations. Very good learning.
Thank you, sir. Thank you.
Yeah. Next case. Next presenter. Dr. Vijay is presenting now?
Yes, sir. Yes, sir. I'm sharing my screen.
Okay, Vijay.
So I'm Dr. Vijay. I'm a consultant neurologist at KIMS Gachibowli. I'll be sharing few of my recent cases where I thrombolized. The first case is The first case is 71-year-old lady with acute onset speech difficulty, noticed at 11:45 on 16 December. She was brought to our center in the time window. On presentation, she was very drowsy with a GCS of E2, V1 and M5. Pupils were equal. The doll size little sluggish. After 10 minutes, there was minimal improvement in sensorium. Initially thought of some metabolic cause. We have then GRBS was 149. She had a past history of tachybrady syndrome for which she underwent pacemaker, and she is a known hypertensive diabetes and known case of Parkinson's. And this was the MRI showing a huge infarct in the left cerebellar hemisphere involving the pica territory. And flare was not showing any flare was not showing any changes. So it's a hyperacute infarct involving the pica territory of the cerebellum, involving almost half of the involving the left half of cerebellum. So the thing is whether thrombolized now or not, because of his her age and involvement of posterior fossa infarct and probable cardioembolic etiology, which are the high risk factors for post thrombolysis hemorrhagic transformation. So we have made a decision and we discussed with the family relatives. They are okay. They are willing for a thrombectomy. So after and this is an angio MRI top showing non-visualization of bilateral vertebrals and also reduced flow in the right ICA and its branches. At 3 hours after the onset, after all the MRI is done, we have thrombolized her in the ER. And the next day CT is looking only some edema which is effacing the fourth ventricle, and there is it is showing some evolved infarct in the same area, but there is no hemorrhagic transformation. And she recovered her sensorium. Her GCS was normal. Eventually, she became normal, and we started on anti-edema measures along with antiplatelets. And this is the fifth day CT. It is also showing resolving edema and there is opening up of the fourth ventricle and some specks of tiny hyperintensity, may or may not be a bleed. It was there, and she was eventually discharged with an MRS of 1. She has only mild slurring of speech when she was discharged. So the risk factors for hemorrhagic transformation include atrial fibrillation, advanced age, higher NHS at onset, longer time from stroke onset to treatment, lower CT aspect score, large cerebellar stroke, and hyperglycemia. In this, we took a call and we proceeded for thrombolysis. Eventually, the patient became normal. The second case is a 55-year-old male with previous history of chronic rheumatic heart disease, underwent MVR. Now presented with sudden onset of right upper limb, lower limb weakness, slurring of speech, reduced word output, and deviation of angle of mouth. Noted at 7:30. He woke up at 6:30 a.m. and he noticed symptoms at 7:35. So it is not a wake-up stroke. So on presentation to the ER, his GRBS was 550 milligram percentage, and examination showed poor comprehension, aphasia, dysarthria, right UMN facial weakness, moderate weakness of right upper and lower limb with an NIHS of 10. He was immediately given appropriate dose of insulin and shifted for CT brain. And CT is not showing any early ischemic changes, and so we proceeded for thrombolysis, that is after 2 hours of onset of symptoms. Post thrombolysis, there was reasonable good improvement in aphasia and motor weakness examined 30 minutes after thrombolysis. And this is the MRI post thrombolytic. It is showing the acute infarct involving the posterior limb of inferior capsule in the left MCA territory, and MRI showing M1 cutoff, left MC M1 cutoff. So we discussed the mechanical thrombectomy option. Then they were willing for that, and the patient immediately underwent a mechanical thrombectomy. This is a pre-mechanical thrombectomy. It is showing M1 cutoff and faint flow in the inferior branch of M2 branch. And post mechanical thrombectomy, there is sticky 3 flow achieved, and there will be complete visualization of all the M1 and M2 branches. The patient NIHS significantly improved and he was discharged. And next day morning CT was showing only evolved infarct. It is not showing any hemorrhagic transformation. And case 3 is a 43-year-old male with history of aortic valve replacement. For indication is severe AS due to bicuspid aortic valve. He was on vitamin K antagonist acetrom 2 mg, and last documented INR was 1.6. He had a history of 1 episode of seizure 5 years back, well controlled on phenytoin. And now presented with acute onset of weakness of left upper and lower limb at 6:30 p.m. while he was climbing step, associated with facial deviation and slurring of speech. He was shifted to our center at 8:30 p.m. Presentation GCS was E4V4M6. Neurological examination, left human facial weakness, dense motor weakness of left upper and lower limbs, dysarthria, mild sensory dulling. NHS was 14 and MRS was 4. And this was a CT done by the ER team, and they have sent me. And the ER physician informed me that there is some bleed. So I asked which is the side of weakness. He told left upper and lower limb. Then I asked what is the site of so-called bleed. He said that is on the left side. So the weakness and the so-called bleed, it is not matching. So this is looking like some venous malformation or cavernoma. You do an MRI, we'll see what it is there. So this is the MRI. MRI showing acute infarct in the right MCA territory involving posterior limb of internal capsule. And so now the decision is whether to thrombolyze or not in view of venous malformation. So because of high NH and young patient, we have decided to go ahead with thrombolysis, and tenecteplase was given at a time window of 3 hours. And post tenecteplase, there was no hemorrhagic transformation or bleeding at the site of cavernoma or at the site of infarct. So there was improvement, moderate improvement of NIHS and weakness. The NIHS improved from 14 to 9. So one more case, a 65-year-old male with long-standing hypertensive diabetes on irregular medicines. Now acute weakness and aphasia from since 2 a.m. He was last seen normal at 10:30 a.m. on the same night. He woke up at 2 a.m. He went to washroom and he fell down. So the patient reached Kim's Hospital at 3:15. That is 5 hours 15 minutes after last seen normal. So neurological examination showed severe aphasia, dense weakness of right upper and lower limb, and right human facial weakness of NIHS of 18 and MRS 4. And this is a diffusion mismatch because we don't know what is the exact onset of the symptom, but from the last seen normal, it was 5 or 15 minutes. So it is showing diffusion mismatch. So it may be the onset may be less than 4.5 hours. So it is showing acute infarct involving the left MCI M2, patchy M1, insula M5, and patchy M4. And flare is not showing any changes. So MRI top showed non-visualization of entire left ICA. So we have done a thrombolysis. There was no worsening of symptoms of post-thrombolysis. We gave an option for mechanical thrombectomy. However, the family denied and they went LAMA. On post. Okay. The next case is a 80-year-old lady with previous hypertension, right history of right MCA stroke in 2024. Now acute onset of left upper limb, lower limb weakness and dysarthria at 5:10 p.m. She presented to our hospital at 7 p.m. on the same day. Presentation GCS was E4V1M6. Neurological examination, mild human facial weakness, no hemianopia. Motor examination showed dense left upper limb more than lower limb weakness. NHS was 11. This is the right MCI infarct involving M2, M5, insula, patch M1 and M4. Flare was normal, again diffusion mismatch. TOF could not be done due to technical reasons. And this is the next day CT, which is showing evolved infarct in the same region in the right MCA territory. However, there was a hemorrhagic, small dot of hemorrhage in the left cerebellar hemisphere, which is away from the side of from the site of infarct. So it was very small and she did not deteriorate in her GCS. We were managing with 1 or 2 days of hypertonic saline. Eventually, she improved her sensorium fully, and the recovery was sustained, and eventually she was discharged in a good condition. And two more cases. The sixth case is 78-year-old with previous history of hypertension and stroke. Presented with acute onset left upper and lower limb weakness and slurring of speech with facial deviation at 10:30. And examination showed dysarthria, right conjugate gaze palsy, left human facial weakness, left hemianopia, and moderate upper limb and lower limb weakness. NHS was 13. MRI showed right MCA infarct, and MRI showed M1 cutoff. And she was given thrombolysis at 2:20 p.m. And this is the infarct involving major MCA territory. Again, same case, M1 cutoff is in, and however, these people were also not willing for mechanical thrombectomy. Next time we have done a CT. Despite of the large area of involved MCA, there was no hemorrhagic manifestation, and slowly she managed conservatively with anti-edema measures, and slowly we have antiplatelet, and slowly eventually we have discharged her in MRS 4 situation only. This is a 78-year-old male with previous history of hypertension, now acute weakness of left upper and lower limb at 2:45 p.m. with facial weakness and dysarthria. He was shifted to hospital at 3:20, that is within 35 minutes. Presentation GCS was E4V4M6. Examination right conjugate eye deviation, left hemianopia to menace, left human facial weakness, dense left upper and lower limb weakness, mild dysarthria. NH was 17. And this is showing a hyperdense MCA sign, but early ischemic changes were not so evident. but it is showing hyperdense MCS sign. So in view of this, the shorter window period of 40 minutes, we have given a tentative place. Even considering his age around 80 years, we decided to get thrombolysis. And post thrombolysis, this is the MRI. MRI showing acute infarct involving the right MCA involving insula and M2. Player is not showing any changes. And post thrombolysis, MRA showed this distal migration of the clot. Initially, there was hyperdense MCA sign. Now we can see that there is a filling here till the distal MCA M1. Post distal MCA M1, there was low flow, means maybe the thrombus has migrated distally. So this indicates maybe the effect of tenic place, maybe some recanalization and migration of thrombus took place. And the repeat CT did not show any hemorrhagic transformation despite his being older age and hyperdense MCS sign on CT. The last case, 80-year-old male with previous hypertension with acute weakness of left upper and lower limb at 2:45 p.m. With facial weakness dysarthria. He was shifted around 3:20. Sorry, this is another case. The CT was showing early ischemic changes involving M4, M6. CT aspects was 8. And MRI showing acute infarct in the right MCA, and MRI top showing the distal M1 and proximal M2 branches. There is a reduced flow, and we have thrombolized the case. And next day there is a tiny speck of HI1 grade of hemorrhagic transformation. The patient was there with us for approximately 10 days, and eventually we discharged him in a very reasonably good condition. Thank you, sir.
No, Dr. Vijay, you had many cases, and I am sure all of them are very nice cases, but it was a very rapid fire kind of a situation. So what I suggest is that if you can once again show us these 8 cases and just summarize what is the lesson from each case, one lines, and we can have a discussion around it.
Yes,
So
sir,
which
yes.
means that we don't want the whole history because you already presented that, but what was the main dilemma and what was the lesson learned from that? Praveen, what do you say?
Yes, sir. Definitely, sir.
Yeah. And
I
then if we
just
have any
I will
comments,
recall
so
one
there's
or two cases.
because we have got a big audience also, so we want them also to learn from this. So you can just summarize, in
Sir,
one or 2 minutes.
this is basically cerebellar infarct, huge cerebellar infarct in an elderly, around 73-year-old female with
Yeah.
underlying probable cardioembolic etiology. So all these things may contribute to the increased bleeding tendency, increased hemorrhagic transformation because of posterior fossa location and involving major cerebellum and probable cardioembolic etiology. So
What was the cardioembolic source, Vijay?
she has a tachybrady syndrome. She is on
Thick sinus
permanent
syndrome. Okay.
pacemaker.
Yeah.
Yes.
Yeah. Okay.
So considering this, we were in a dilemma to thrombolyze or not, but she was very drowsy at that time. We thought we'll take a call and we'll thrombolyze. But luckily, she improved. She did not have had any hemorrhagic transformation.
So I think the lesson from this is that if the patient is within the window period,
Yes, sir.
which is within 4.5 hours, irrespective of the size of the infarct, and irrespective of the location of the infarct, we should thrombolyze them, but we have to be very cautious and ready,
Yes.
as you rightly said, for hemorrhagic transformation, in which case they may need some neurosurgical intervention.
Yes, sir.
So we should thrombolyze, but be ready for any eventuality.
Yes.
So that is the take-home message from this.
Yes, sir.
But we should thrombolyze them.
We should
Yeah.
thrombolyze. Yes.
Second patient.
Second patient also likely cardioembolic, sir. So CT is not showing
What
any.
was the cardioembolic source here?
The case of CRHT, status post mitral valve
Okay,
replacement.
metallic valve.
Mitral, yes, sir.
Yeah.
So he completely recovered. The take home message is post thrombolysis also. When the patients here, there was no flow seen in the distal M1 or the M2 branches. When
Yeah.
we took the patient to the mechanical thrombectomy, there is subtle flow. We can see in the inferior branch of inferior M2 branch. So this indicates after thrombolysis and while shifting to the cath lab, maybe the flow got restored by the time he reached the cath lab. And after thrombolysis, there is good flow of the MCA M1 and M2 branches.
But he still underwent mechanical thrombectomy, right?
Yes, sir, yes, yes.
Because it was not a complete recanalization, right?
Complete recanalization, no, but there was partial recanalization.
Yeah. Praveen, any comments? This is straightforward. No, it's
Yes.
straightforward. Yeah.
One thing, definitely patient must be on anticoagulation. Therefore, INR, I missed the INR. What was
It
the
was
INR?
1.6. 1.6, Praveen.
Oh, yeah,
This
that's fine.
patient,
She just made it.
Yeah. 1.6.
If it was 1.8, if it was 1.8, probably you would have gone directly to MT.
Yes.
Yeah.
Yep.
Okay.
Next.
Yeah. Next.
so the thing is, the tenecteplase is like favorable outcome, like in the bridging thrombectomy. That's what I'm
Yes.
going.
Yes.
Yes.
Trial after
No,
trial so that tenecteplase is
no.
superior to alteplase.
As a matter of fact, sometimes the tenecteplase recanalizes completely, in which case you may not even do the mechanical.
Yes.
But here it did only partial, so that you still had to do mechanical.
Yes.
Right. Yeah. Third case.
So this is also cardioembolic, sir. She's a post atrial valve replacement. This INR was 1.6, sir. Not the other one. INR was not there.
Okay.
So the thing is here, the patient has a cavernoma. So the dilemma is whether to thrombolyze or not.
A cavernoma, I think so. We should go ahead. It should not normally doesn't bleed as much.
Cavernoma is not a contraindication. AVM also is not a contraindication.
Yes, sir. Yes.
And
So,
the unruptured aneurysm also is not a contraindication.
Not a contraindication. Yes.
So considering his age, it is like relatively a bigger cavernoma. So this, despite it, we thrombolized, but there was no uneventful events. So the patient became normal. So that the take
Great.
home here is, even with cavernomas or cortical microbleeds, we can thrombolize a patient.
Yes. And all these things are telling us that MRI is a much better investigation than CT scan when we
Sir.
have to thrombolize patients,
Yes.
because they show you a lot more.
Yes.
Okay. Yeah. Fourth case.
Fourth case. Fourth case
Yeah.
is of diffusion mismatch, sir. We don't know the exact onset of weakness. He was last seen normal at 10:30 and they brought to the hospital at 3:15. So it was post window period. It's more than 5 hours. So, but the MRI showing mismatch. So because of mismatch, we have thrombolized the case. Only that is the thing, sir. And
Was this a wake up stroke in the night?
he woke up at 2 o'clock in the night, sir, midnight.
Yes.
With weakness.
So you are right in this. He woke up in the midnight, and you are having a diffusion flare mismatch. So
Yes, sir.
once you have a diffusion flare mismatch, then you don't worry.
Yes.
When has he slept and all. Once the mismatch is there.
Yes.
So you are completely correct in.
Yes,
Yeah.
yes. So we
One
went
point,
ahead.
Vijay. Now we have yesterday only guidelines are released for the acute stroke, and I just skimmed through it. What they are suggesting for 4.5 to 9 hours in selected cases, we can also thrombolize, but we have to do the perfusion there. And if
Yes.
the perfusion is there, now it has coming into the guidelines also. Therefore, for all cases beyond 4.5 perfusion, and if you have a good penumbra, I think so we can thrombolize there also. Sir, what do you
Now,
suggest, sir?
no. I'll tell you something. It's very interesting that you are talking about the 9 hours, right?
Yes, sir. 4.5 to
But if
9.
you are talking about the 9 hours, that means if a patient, so we'll think of two situations. One is the one in which the patient woke up from sleep when you don't know, and second is when the patient was awake, right? So if the patient is awake, like in the evening at about 7 o'clock, he gets a stroke. Or he comes to hospital at 7 o'clock in the evening and he has suffered a stroke in the morning. So, you know that it's now 8 hours, he's within 9 hours. So you do a perfusion study, Praveen. And
Yes, sir.
perfusion studies shows you that there's a mismatch ratio of 1.2, right? So you can go ahead and do it, right?
True, sir.
In that 9 hours, diffusion flare is not a criteria. It's the perfusion which is the criteria. Correct,
Yes, sir.
Praveen?
Yes, sir. Yes, sir.
Yeah. Now, suppose if the patient is sleeping, this is interesting. If the patient is sleeping and he has woken up from the stroke, right? And he has woken up from the stroke, and in the diffusion flare, you find that there is not a mismatch. Even in him also you can do perfusion. Praveen,
Yes, sir. Yes.
you understand point?
Yeah, got
The
it, sir. Got
person,
it.
I mean, according to diffusion perfusion mismatch, if we disqualify him, which means flare has already come, but still don't disqualify him. You do
True,
a
sir.
perfusion mismatch in him also.
True.
But for this perfusion mismatch, you have to meet two criteria. One is that there has to be a perfusion mismatch of 1.2. Second is it has to be within 9 hours.
True, sir.
Now, if
True.
the patient is wakeful, then 9 hours. If the patient is sleeping, then how do you know 9 hours? Now, in that also they have made a formula. The formula is that from the time he went to the sleep to the point he woke up, the half of it should be within 9 hours.
Yeah.
Have they mentioned that in the recent guidelines, in the yesterday's
No, sir.
guidelines,
I
or
have
no?
to. No, sir. I have to read all of it. I was just reading. No, sir. Maybe
Yes.
fine
Yeah.
print will be there.
So that no, it is very interesting because I have gone through the literature that in the awake patient you can know whether it is within 9 hours or not. To summarize for the people who are watching at this time, to summarize is that the perfusion study enables us to give IV thrombolysis within 9 hours. Now, for a wakeful patient, it's easy to know 9 hours. For a sleeping patient, how do you know 9 hours? There you arbitrarily assume the time of onset of stroke as the midpoint of his sleeping period, right?
Yeah.
So that is arbitrary, but that is allowed in the trials. So I think all of us should go through that whether they have mentioned this point or not. So anyway, the bottom line, Praveen and Vijay, is that this year is the year of extension of the window.
Yes, sir.
Now people are talking of the extension of the window up to 24 hours. But I think new guidelines may not have yet allowed for 24 hours because there is not still more data. They want more data. But up to 9 hours now we have to give up to 9 hours. But not with the help of diffusion flare alone. We need perfusion study for that.
Yes, yeah. Yes.
Okay, great.
Yes.
So I think this is also good. So in this case, what was Vijay? What was in this case the issue? That
The
yeah,
wake up
you didn't know exactly when, but because there was a mismatch, based on mismatch, you thrombolized and patient did well. Yeah.
Yes.
Sir, they are here saying in the guideline it is diffusion weighted image or perfusion based mismatch. So they are not saying both are essential. Essentially, they're saying all.
Okay, I think we'll go through that. We'll see that because for in the 9 hour study it was done that extent. It was an extent study. They did
Extend.
it based on perfusion, but I don't know whether they did it on diffusion alone for 9 hours. I don't know. This diffusion flare mismatch was restricted only for sleep study, but not up to the 9 hours. But I think we need
Because
to
in
check that
Australia
again.
they do mostly perfusion, so all these extent studies are from Australia, and so they are
Yes, yes. Praveen, what is the guidelines saying about this 9 hours? Do they say that even diffusion alone is enough, diffusion flare?
No, sir. No, sir. Perfusion has to be done, sir.
Yeah. It's to be done.
Perfect.
Okay, go ahead, Vijay. Next.
So next case, sir, regarding age, sir, all the elderly people around say 80 years. So 8 years within time window. So we went ahead with thrombolysis, and one patient was showing uh, two patients showing a minor bleeding thing, but eventually they recovered. So I want to
Yeah.
emphasize that age is not a criteria. We can go ahead.
What was
Whatever.
your
Definitely.
age?
80,
80,
sir.
sir,
80.
80, 80.
80 is young, yeah. You should not even bring the discussion of age about 80. It should have been if patient had crossed 100.
Okay.
80 is very young.
Yeah, great.
So
Okay.
all are around 80, sir. So I thought I'll include these to tell
Yeah.
that
Okay.
we can
That's
encourage
okay.
Okay,
to.
no, that's fine. We get the point. We get the
Yes,
point.
yes, sir.
But that's a point well taken. And in fact, when the thrombolysis started, they were very strict about this 80. Very, very strict. Now, gradually, the people, because most of the people who get stroke in Western countries are above 80. So
Yes.
then the first, I still remember we were part of that study. It was called International Stroke Trial.
Yes, sir.
There were three IMS trials. It was IST trials. The third one was they took two things in third international stroke trial. It was actually, we were also participants when we were in Nizam Institute. So in that, one thing was that they had extended the window up to 6 hours, and the age was taken beyond 80 hours. So up to 6 hours could not be accepted, but age was accepted beyond 80. But, so you are right. Initially, it was a very strict restriction, but no longer so. Now we can go ahead. Okay, case 5.
Sir, rest all the cases are based on age, sir.
That's okay then.
This is
Okay.
one hyperdense MCI sign. This is also hyperdense, one of the poor predictors. Like it will one of the factor for post-stroke hemorrhagic transformation, but the patient did not have any.
Okay.
Yeah. In fact, hyperdense MCA should make us ready for the mechanical thrombectomy.
Yes, sir. Yes, sir.
But let me tell you, hyperdense MCA can sometimes be a false positive also.
Yes,
50%
sir.
of them have just slow flow and not always.
Low flow. Yes, sir.
And you are
Polycystic.
right that sometimes and I have seen this, I have seen it myself, that sometimes some patients worsen with thrombolysis because of the distal migration of the clot.
Yes, sir.
You know, they go ahead and block the distal vessels. But this patient did well, right?
This patient also there was distal migration, but no hemorrhagic transformation. This patient survived. That is the thing, sir.
And this is a very well-known phenomena for this mechanical thrombectomy. Sometimes that some clot remains inside or it migrates distally. Then they give intra-arterial thrombolytic agent in addition to the mechanical, mainly to go to the small vessel and leave those, suck out those residual clots which have migrated distally. So that is good. And next.
Yes, sir. I'm done with
That's
this.
it, sir.
Yes, sir. That's it.
Done.
Yes, sir.
So I think we had all the great cases today. Both speakers did great justice, and we learned
Wonderful, sir. Yeah,
many
yeah.
new things. Now we are more confident in thrombolizing, and I'm sure the audience will benefit and they will see. But there's no doubt that we have now become more confident in thrombolizing, but at the same time we have to be very careful. We should not think that nothing will happen. Sometimes bleeds do happen. So we have to be mentally prepared that I am taking a high risk for the benefit of the patient. But if the bleed occurs, what will I do? We have to constantly watch for that. We should not, what I'm saying, it should not make us complacent. It should make us more careful, and we should, because bleeds will still happen. It's not that the bleeds don't happen. They still happen. So we have to be careful, but at the same time, we should just do it, whenever, as far as it's possible. Praveen, your comments from your
Yeah.
experience.
Today only, sir, we had a pontine infarct. Patient came in 1 hour. BP was 200. We gave labetalol, came down to 160, thrombolized. But after 1 hour, it shot up to 240, and he had a brainstem bleed, sir. Feeling very
Yes,
bad about it,
yes,
sir.
yes.
But
Yes.
yeah,
The other thing in thrombolysis is that we should not thrombolize when it is not necessary. Of course, in your case, it was necessary, but we have
yeah,
to be ready that the bleed can happen. It
yes,
will
sir.
happen if you go by data, if you go by strict data, it will happen 1 in 14.
Yeah,
You
yeah.
know, when the thrombolysis came first, one young doctor told me, "Oh, I have never faced a bleed." So I asked him gently, "How many you have thrombolized?" He said 6. I said, "Wait, it will happen in your 14th patient." And after 1 year, he met me. He said, "How did you know that it will happen?" It did happen on 14th, and it happened in 15th also. I said, "That is what the data is, you know." So therefore, we have to be so. What I'm saying is that we should not deny thrombolysis where it is required, but at the same time, we have to be ready that the bleeds will happen sometimes. And but I think today's cases were fantastic. The outcomes
Yes.
were very good. And any comments from your side?
No, sir, they're wonderful. Any questions are there?
Sir, I just had one question. So, sir, have you done any intra-arterial tenecteplase administration? Because there have been some studies after mechanical thrombectomy, Dr. Paul sir mentioned. And what was the dose used? Generally, in these studies, some studies are from China. They have used 0.02 mg per kg. What has been your experience?
I think this is a question to Vijay.
Anyone, sir, you can also answer if you have any experience.
No, we have not. I have only read about it. We discuss it in the meetings and conferences, but our interventionalist does not do any
No, sir.
intra-arterial so far. But this is a very hot topic to remove the residual clot. But Vijay, have you done any intra-arterial along with the?
No, sir. No, sir.
This is thought to have particularly the role in the medium vessel occlusions or the distal vessel occlusions where you cannot negotiate that disposable stent. There has a role, but it has not yet come to guidelines, but it can be done in that. But we have not done it.
Okay.
So if there is no questions or comments, then I would request the organizers to take over and thank the audience.
Thank you.
Thank you so much, sir, and also to all the both speakers for sharing such wonderful cases with us. I'm sure the audience really took away a lot of learnings. And again, I'd like to thank each and everyone for their precious time. Thank you so much, sir, and thank you so much to all our
Thank
speakers.
you. Thank you. Thank you.
Thank you.
Thank you, sir.